as we follow them for 12 months, we see that folks that had stimulant use disorder but did not receive contingency management were more likely to ultimately die. And then those who receive contingency management were, as you already pointed out, about 40% less likely to ultimately die in the year following. And so
Welcome to Dopamine Dialogues, the show where we meet experts working with contingency management, translating the science into what actually succeeds in clinics, communities, and day-to-day operations with patients, clients, and beneficiaries. So whether you're a provider, payer, policymaker, or just CM curious, you're in the right place. Because here at Dopamine Dialogues, we believe in positive reinforcement. I'm your host, Larry Klemchak. It's with great pleasure we welcome our guest, Dr. Lara Coughlin. Dr. Coughlin is a licensed clinical psychologist and an associate professor at the University of Michigan Addiction Center in the Department of Psychiatry. Dr. Coughlin, it is great to have you join us here on Dopamine Dialogues.
thanks so much for having me today.
Hey, can you please start off by just telling us a little bit about yourself and your role, and share with us how you became interested in addiction care?
Absolutely. The story sort of goes back to I grew up on a rural farm, and I really saw the impacts of addiction through my childhood and my upbringing. However, I had the great privilege during my training in graduate school of working in a really amazing behavioral economics lab. So, behavioral economics is the study of how real people make choices. And in the context of addiction, really understanding how it is that people, oftentimes knowing that substances can be detrimental, dangerous, make choices to use them in a way that ultimately can lead to consequences. And if you talk to 100 people, none of them are going to tell you they want to have a substance use disorder. So I got really interested in this idea of how we can shift decisions towards healthier behaviors. Then fast forward to my time here at University of Michigan, I've had great luck of getting to really work with a focus on taking what we have in our addiction field, in our addiction care field, and thinking about how we can make it more engaging for more people that are using substances to make sure that they get the care. Because sort of one thing that's been a foundational thought for me and knowledge is that only about 10% of people with a substance use disorder ever actually receive any sort of care or treatment. And so we have a long way to go if we really want to have population health impact.
Wow. Well, thank you very much for that. So that's very interesting to, hear what your interests really are, and that you got into this through behavior economics, really. And
Okay.
I imagine, the desire to help people change. The last comment that you had, Dr. Coughlin, was that only about 10% of people with substance use disorder are actually getting treatment. Can you just expand on that a little bit?
It's really interesting because there's multiple reasons that we could say the vast majority, 9 out of every 10 people with a substance use disorder don't receive any treatment. There's some good news here. Some of those 9 people that don't receive treatment will actually resolve their substance use disorder on their own. This is amazing. There's options for people outside of treatment. However, for many, there's other reasons that they're not receiving treatment. Some of those have to do with sort of structural barriers, living far away from a place where they can receive addiction care, lack of awareness that there are treatments that work for addictions. And then for some, though, there's the experience of the what's out there for addiction care really isn't the type of treatment that they believe, and people often do know for themselves will work for them. They aren't very appealing. Some of our treatment models in the addiction field, unfortunately, still really come from a place of sort of stigma and shame and can be really pretty demoralizing for people to engage with. And so a big area of focus for me is how can we really impact that space of reducing stigma? I would love to eliminate stigma in the addiction field, of increasing the appeal and having treatment options for people that both work and are something that people can actually find to be empowering for them. And so that's been a really big focus of trying to bring that type of frame to the addiction field, which really differs from sort of addiction treatment of the 80s and 90s.
Interesting. And so I guess what I'm hearing you say, Dr. Coughlin, is really understanding what more can we learn about this patient or client, and then adjusting how we help them based upon their particular needs. And certainly not a one size fits all equation is out there, right?
Exactly, and making sure that people know about treatments that work and that we have treatments that work not just at academic medical centers, but at the community clinic that might exist in a town with a population of 1,000 people, making sure that addiction care that works, that is effective, is widely available, which we have a lot of work to do, but we are making a lot of progress in this space.
Dr. Coughlin, you're particularly interested in interventions rooted in behavioral economic frameworks, including incentive based interventions like contingency management. How did you latch on to contingency management and, see that? I mean, I guess it is very closely to behavioral economics, but maybe I'd like to hear your story.
So in the behavioral economics field, we really like to claim contingency management as like this great example of a treatment that works in the addiction space and works in other spaces, but really works well and has been robustly studied in the addiction space and comes back to this idea of we have two reinforcers, right? We have a drug that is a reinforcer, and then we have an incentive, a reward, oftentimes money that is a reinforcer. And we can actually shift people's choices, which is pretty powerful. We can shift people's choices by providing the option of immediate alternative reinforcers in the form of an incentive. And I think a real key that you mentioned, Larry, that I really appreciate is that by offering people an incentive that is monetary, oftentimes that is just sort of the foot in the door for people actually engaging with other reinforcers that are recovery oriented, for people, taking their kids out and having a really joyful time, but having the resources to do that, for people getting engaged in physical activity that's reinforcing. And so we find that these small, relatively modest monetary reinforcers that are sort of a cornerstone of contingency management interventions really help to sort of counterbalance the powerful reinforcing effects of drug use in the moment and make recovery oriented behaviors more rewarding. So it really does come down to the same behavioral economic idea of how can we take the choices people are making and help to shift them towards healthier choices.
Last year, you were published a very powerful study, and I love the part of the name of this was fewer deaths are seen among veterans incentive-based drug recovery. And then it goes on to say a 41% drop in risk of death. Death. And we're not talking about abstinence here, but that's a big number that you're saving lives. Can you share with us, what inspired you to do this study, and then maybe a little bit more about, what are some of the takeaways from that study for our audience? Because I think a lot of our audience are going to go seek this paper out and read it after this.
For sure. So this was a partnership that only could happen because we had amazing support by the Veterans Health Administration Central Office. The Office of Mental Health was supportive of us doing some evaluation work of their contingency management program. So the first thing to know here is the VA has really led contingency management way before states started to pick it up. So VA started doing nationwide CM rollout in 2011. Before this was really coming off of the 90s and early 2000s, which were really rich and amazing evidence coming out that, wow, contingency management really, really helps. It helps across a lot of different behaviors, but in stimulant use disorder, it is a really great option. It is our first line treatment. And so VA ran with that and they rolled it out. VA is the largest addiction care provider in our country and is our largest national healthcare system. And so we approached VA because we really wanted to look more at the contingency management program that they'd been doing for decades. And they were amazing partners in this. So we did a few preliminary studies just to sort of characterize what CM was looking like in VA, who was receiving CM. And then we decided to sort of go for this larger question that many have been asking for a while, but it's just the data hasn't existed to look at it, which is among people who receive contingency management with a stimulant use disorder compared to those with a stimulant use disorder who don't receive contingency management. What is the impact on that sort of ultimate outcome? And here, what we're talking about as an ultimate income is mortality or death. And I can give you a little bit of tidbits about this study. So ultimately, we are looking at veterans in the VA with a stimulant use disorder between 2018 and 2020. And of that, we had about 138,000 veterans with a past year diagnosis of stimulant use disorder. And then we were looking within those people, those who received contingency management and those who didn't, and we matched them. And we ended up with about 1,400 veterans in the VA who had received contingency management and 1,400 veterans who didn't receive contingency management, all of them with a recent stimulant use disorder diagnosis, and matched on things like their gender, their race, whether or not they were stably housed, whether or not they had other substance use disorders, other mental health diagnoses, really with the goal here of ending up with a fairly comparable cohort of 1,400 people on both sides. And then we followed them for a year, and we looked at how they did, both like what type of services they were getting, but ultimately looking at survival. And what we were able to see doing this is that as we follow them for 12 months, we see that folks that had stimulant use disorder but did not receive contingency management were more likely to ultimately die. And then those who receive contingency management were, as you already pointed out, about 40% less likely to ultimately die in the year following. And so this actually held. We saw similar
Sorry, Dr. Coughlin.
patterns.
In
Mhm.
just the 1 year following?
Yeah, so one
Wow.
year, and
Wow.
so
I thought this
y-
was like maybe, like 5 years after or something, but in the 1
yeah,
year, there's a 41. Wow. That I mean, that I'm just getting goosebumps, to be honest.
that's
I had no idea it was in 1 year follow.
yeah. So
Okay.
it's a
Yeah.
1 year follow up, and I'll say what this is. Yeah, to frame it within the addiction treatment field, this is sort of a similar magnitude of effect as what we see from similar types of work done in buprenorphine, which is sort of one of our frontline treatments for opioid use disorder. So when someone with opioid use disorder receives buprenorphine compared to someone who doesn't with opioid use disorder, it's a similar magnitude of reduction in likelihood of them dying in the subsequent year. We also saw fewer overdose deaths. So we looked at like what I was telling you is for all cause deaths. So people could die from lots of reasons. Also see for fewer overdose deaths. We see fewer stimulant involved deaths. And so really the take home here is, well, this is in one very large health system, but one health system. So I think that there's a really great opportunity to look at this in where other large scale CM rollouts are happening. We see really the first evidence that's come out that contingency management really is saving lives. And this is really powerful when we think about how much we should make sure that this is a treatment that is available to people that are using stimulants, whether those be methamphetamine or cocaine, whether that be that you're using them in a really rural area or more urban area. We need to figure out how this treatment can be as available and push it forward as much as we have for things like buprenorphine, which has been over the last decade really incredible initiatives to make sure that buprenorphine is available to people that could benefit from it.
Saving lives. That's what it is all about, and that's beautiful. You've had experience, obviously, working alongside, somebody as big as the VA, but I know you've had many other projects and studies. Could you just share a little bit about what things in the area of implementation, like workflows, staffing, training, et cetera, and fidelity considerations, somebody who's embarking on a CM program and they want to make it successful, what advice would you have for them in those areas?
Yeah, I think we're learning a lot as a lot of different health systems and departments of health are taking on bringing in contingency management in widespread form. I'd say my first one is not to build it from scratch. So we're seeing departments of health, for example, that just sort of decide to come up with their own contingency management protocols, their own plan for implementation. And you're not alone. You don't have to do this. And we have not only really strong evidence base, but also other programs in other states that have done this that we can learn from what's worked and what hasn't worked. So my first piece of advice would be, please seek consultation, reach out to states that are implementing. If you don't know who to reach out to, reach out to me, and I'm happy to point you to people to talk to about it, because we really want to make sure that people are sort of not having to bite this off on their own. And because a challenge with contingency management is it doesn't really look like our evidence-based psychosocial therapies, and it doesn't really look like a medication. And so working it into a clinic and a workflow, it's not that it's impossible, it's just that it sometimes takes a different nuanced approach. My other piece of advice I'll offer is that oftentimes clinics and systems are really focused on the initial stand-up and training and getting it off the ground. And I think just as important in these efforts is the continued coaching, the continued technical assistance, the continued bringing together providers and clinics that are providing contingency management so that they can share knowledge with each other. And sometimes that is where we see a little bit more of a drop off and risk of loss of fidelity. And the reason loss of fidelity matters is because sometimes that can have two implications. That can have an implication of sort of loss of effectiveness of the treatment. Can also have implication of sort of loss of sticking to like core pieces of contingency management that we know are important to make sure it stays legal and above board in all sorts of ways.
That's excellent.
Mm.
I guess my takeaway there was first and foremost, Dr. Coughlin, hey, why do the heavy lifting on your own? Go talk, go talk to some people that have done this and listen to them about things to avoid and things to really focus on for success of the program. And I
Yes.
think the next thing that I hear you on, I completely agree with as well. It's not a one and done. It's a continual training to ensure that you're getting the maximum benefit of the treatment process. I was going to ask you what misconceptions maybe are still out there about CM, because, if we keep to the fidelity of the program, we're going to avoid some of those misconceptions. But hey, misconceptions are still out there. So,
Sure. So I think CM, one of the challenges is this again, it's a different model than what a lot of people think of with about addiction care. It's not going in and just talking for an hour a week to a counselor, and it's not going in once a month and talking to your doctor and getting a med adjustment. And it seems to be a sticky thing that sort of misconceptions or myths can sort of proliferate in this space because it's different. And I would say maybe in some ways that difference is good because contingency management is maybe one of the best things about it is it really appeals to people. It really switches the script for people. Instead of your provider being someone who's trying to catch you slipping up, returning to use, your provider being someone who's there to celebrate your wins with you, celebrate that you didn't use today, even though you used earlier this week. And so this change to positive reinforcement makes the addiction treatment process much more positive for patients. And actually, ultimately, we hear from providers much more positive for them. It is a Providers really want their patients to be doing well and have that focus on when they're doing well is really positive. However, sometimes that thinking that can creep in are thoughts of sort of some of the misconceptions are around, you know, should we pay people to change a behavior that as a society we might moralistically believe they shouldn't have engaged in the first place? And I just, on those sorts of thoughts, I just tend to keep coming back in our coaching calls and whatnot, providing reminders that, of course, nobody intends to end up with a substance use disorder. There's lots of factors that lead to a substance use disorder. Some of them are our behaviors. Some of them are sort of how we came into this world. Some of them are the experiences we may have had in this world for which among none of us are they the same. And so that piece of if we can provide this modest bit of reinforcement to try to counterbalance those really, again, powerful effects that drugs have, this is really beneficial to the individual, but it's also actually really selfishly beneficial to society. If we can actually help people stop using substances, it has all sorts of reductions in consequences to our criminal justice system, to families being able to stay together, to healthcare costs. If I could say one more misconception that I think is a sticky one that I'll just note is this idea of it's all well and good that we're going to pay someone and that incentive is going to help them in the short term. But what actually happens to them when we stop paying them? Because we're not suggesting that we give people incentives for not using drugs as a forever treatment. And this is a really good question because this is actually in this way, CM is like a lot of other treatments that we have in that when we provide someone with cognitive behavioral therapy, the goal is not for that to be forever therapy. That is time limited, often 3 months or 12 weeks of therapy. And this is the same with contingency management if it's a time limited treatment. And just like cognitive behavioral therapy, when you stop, some people do actually experience some worsening of symptoms, some return to use. And again, this is the same for contingency management. We do see that when incentives stop, there can be for some people some return of symptoms, some return to use. And I think the really important thing to note here is that cognitive behavioral therapy is a first line treatment across all sorts of mental health, behavioral health conditions. And we know that and we recognize that. And we often sometimes will offer, check-ins once a month or going on to help people to get through sort of the transition from frequent therapy to not. And this is the exact same thing for CM. We do see for some people some return of symptoms. And we also see that for many people, they are not having any more return of symptoms than we would expect from any other treatment that we provide. And in fact, there's been some really great meta-analysis that came out a few years ago, which is just a bunch of studies all into one big mega study looking at what happened to people who received cognitive behavioral therapy and other treatments compared to contingency management, and showed that actually, when we look at people as far out as a year, we don't see that there's more return to use, to substance use, more negative outcomes from contingency management than other treatments. So really what that take home there is this idea that when we take away the incentives, the contingencies, people are going to just go back to their old behavior. This doesn't pan out. And when it does, it pans out to the same or lesser degree than we see from any other treatment that we're providing in the addiction space. So I just like to sort of back that with the data because it makes sense why people think that. And it's just not the case because most people don't want to return to using substances. Once they start engaging with reinforcing recovery-oriented behaviors, that is actually more fulfilling for folks.
That was fantastic, Dr. Coughlin. You kind of started off there about, celebrating wins. This isn't about catching people out and everything else or trailing them. It's celebrating the wins and giving them that positive reinforcement for that behavior. And you had a snippet in there talking about how contingency management can be really positive for the provider as well, and helping them like their job and changing some of their mindset with the proper training and fidelity. And of course, if we could lower the overall healthcare costs for society, I think many of us are going to say, yeah, maybe we're okay with being somewhat selfish on that.
Yeah, I think that the many, our federal government would definitely like us to lower our healthcare costs.
There we go. There we go. And your last comment on there about, hey, look, contingency management can be time limited, and the return on investment, if I can use that ugly business word, but the return on investment for contingency management is as good or in better in some cases than some other traditional treatments. So I think that's a really good point to bring up, that once you start a contingency management program, you're not doing this forever, and a lot of people are going to be feeling great and changing their lives. So, and as per your earlier comments, they're going to be alive. So that's outstanding.
That's certainly a major goal. And I will say, I think that a lot of the cost, there's been some cost work on contingency management, but I think a lot is still forthcoming. And we'll see it as, Medicaid evaluations and others look at cost neutrality or cost benefit. I think that that's a space where we really need to think about the big picture. And it's the incentive costs in contingency management are fairly reasonable, oftentimes around $600 as a full course of treatment for an individual. But there's other costs, of course, of clinician time and testing materials and incentive management platforms and whatnot. And so I think that this will be borne out as we have more of these large scale demonstrations going on in our country. And we'll actually learn a lot more about ultimately the short and long term returns on investment.
Thank you. With your experience and all the lessons learned, where do you think contingency management is headed next?
This is really hard for me to disentangle what I want from what will happen. So I just have to
Uh,
acknowledge
we can
this.
do both. We can do both.
But I can at least speak to what I really hope will happen with contingency management. I really hope, as a country that has for quite some time now struggled with a drug epidemic that has taken many different forms, and what types of substances are being used and what types of consequences, whether that be spread of infectious disease or whether that be overdose deaths, that we will set stigma aside and that we will use a treatment that really we have some of the most clear and consistent evidence that the treatment works, in that treatment being contingency management. And what I hope that means is that we will really take a population health impact perspective on contingency management. And what I really mean when I say that is that we'll have a focus on making sure that contingency management is available in the same sort of way that we've been focusing on contingency management, on buprenorphine being available or methadone being available for people with opioid use disorder. And that in doing so, we'll do it in a way that contingency management can be a relatively low barrier treatment for people. And what's important there is sometimes there's a tendency with treatments for there to be some, what we might think of as almost gatekeeping of who can receive it and who can't, thinking about if we can identify like which patients are most ideal, or having additional requirements like, oh, to receive this treatment, you have to also engage in these other treatments. You have to be going to group every week and whatnot. And the evidence around contingency management isn't that you should require other treatments. We should absolutely offer them and connect our patients to resources that fit with their needs and their wants. But I would really love to see a focus on low barrier public health impact for contingency management.
Oh, I do too. That'd be great, have that lower barrier for public health. You also made the other comment there that, contingency management can be standalone, but it also can be augmenting many other treatments. And I read, I know you're very close to ASAM as well, reading many of their reports where you can use these in combination for some unbelievable results. So thank you. I only have one last question, and that last question is there a question you'd like me to ask you?
Oh, that is the toughest question you've asked yet.
You might be saying, "Why hasn't he asked me about this?"
I'd be happy if you're interested just to share a little bit about some of our the research side. I've talked a lot about the practice side of contingency management
Dr.
and what we
Coughlin, we'd
need.
love it. Yeah, that'd be great.
So, in brief, I think there's a few places on the research side where we're sort of trying to move contingency management forward for like sort of the next phase of what contingency management might look like. Because as I mentioned, the 90s and early 2000s really included a ton of work establishing what works for these clinic-based models of contingency management that we're now trying to bring into practice. There's a few spaces that we're researching right now for moving contingency management so that it's more accessible to people without having to come to the clinic frequently. Because for some folks, coming to a clinic, say twice a week, can become kind of a burden. And again, can make it kind of hard to actually engage and receive the care that's going to help them. So we have some work doing this in a couple spaces. One is actually focused outside of the stimulant use disorder. We focus on tobacco use and providing people with both a real coach, but also a digital and app-based platform where they can receive contingency management treatment to help them change their cigarette smoking behavior. And we see really incredible findings from this of people who have wanted to quit for a really long time, but I don't know if anyone listening to this has smoked before. It can be really hard to quit cigarettes. It's actually, some people say it can be harder to quit cigarettes than methamphetamine or other drugs, but all of them, from my understanding, are really hard to quit. And so we try to help people by providing them frequently, multiple times a day, in fact, since it's in their own home or, at their place of work. They could just blow in a little breathalyzer and it tells whether or not they've been smoking, and then they receive rewards, incentives for doing that. We find really great outcomes in that. We also have some research sort of using the same type of platform, but actually in people that are receiving addiction care in clinics, trying to think through ways that we can both keep people who have, say, an opioid use disorder or a stimulant use disorder or an alcohol use disorder connected to their clinic, but also provide them with a contingency management based platform, app based platform that they can use at home so they receive care in between their visits and aren't having to make extra trips to their clinic specifically for contingency management. And we find this to be really powerful. And then the last space is really trying to understand how we can take what we know works for contingency management. And there has, as I mentioned, been a lot of work understanding how much money, how much incentives need to be offered, how frequently do you need to have contingency management visits, how should we incentivize people? Should we change how much money is available, or should we keep it the same over time? And taking all of that knowledge of what's the most important sort of ingredients in effective contingency management, but then trying to understand exactly how far we can go within those bounds of keeping it effective to also make it lower barrier for the patients that we're trying to serve. And so those are sort of the three places that I'm really interested from the research space, both how we can make tobacco and other types of contingency management treatments really accessible to folks, especially folks like people who are on Medicaid or might have less resources, how we can actually make addiction treatment for things like opioid stimulants and alcohol use disorder and contingency management more compatible. And then in general, how we can maybe adjust how we're delivering contingency management to make it easier and more accessible to more people.
Well, Dr. Coughlin, I would really like to say thank you very much. We really appreciate your time and your participation in our podcast, Dopamine Dialogues. So, on behalf of all of our listeners, thank you very much.
Thank you so much for having me. This was really fun.